Hello and welcome to our USMLE Step 2 CK exam discussion. So we here are going to discuss some clinical cases, and we will answer the cases together, and we illustrate the wrong answers and the right answers together. So I will let you think about the answer here, and I will give you time to answer the question, and we will discuss it later. So let's read the question here. A 45-year-old man came to the emergency department 2 hours after motor vehicle collision. Blood pressure is 88/45 and heart rate is 144. There are no any signs of internal or external bleeding, and GFP is elevated, and pulmonary auscultation showed decreased lung sounds on the left side and tracheal deviation to the right side. ABG showed PO2 of 75 and CO2 of 21. So what is the most likely diagnosis here? And here we will examine the answer choices. Here, A, is it tension pneumothorax? Is it cardiac tamponade? Is it internal bleeding? Is it pulmonary embolism? So I will give you a minute to think about the answer here, and we will discuss it later now. So let's discuss the answer here. In the context of trauma, if there is any hemodynamic instability, we should think about three things. Either it is hemodynamic instability due to hemorrhagic shock, or it may be hemodynamic instability because the venous return is decreased, or there is no venous return to the right heart because something is preventing the venous return to the right atrium and to the right ventricle. So in the context of trauma, if there is any hemodynamic instability, we should raise suspicion of any signs of external bleeding or internal bleeding. The next thing, we should raise suspicion of if there is any cardiac tamponade or tension pneumothorax. The idea in cardiac tamponade, the increased intrapericardial pressure because of bleeding, either from the pericardium or from the muscle of the heart. The increased intrapericardial pressure will prevent blood return or venous return from the systemic venous system to the right atrium and right ventricle, and the decreased venous return will also to the right heart will also decrease venous return to the left heart. So we are expecting here hypotension and tachycardia also. So what will differentiate cardiac tamponade from hemodynamic instability due to internal or external bleeding is the GFP. So the GFP will be decreased in bleeding because there is no any blood to return to the right heart in the first place. While in cardiac tamponade, there is blood, or there is blood volume in the circulation, but it can't return to the right heart. So here in cardiac tamponade, the GFP will be elevated. The third thing that we should think about is tension pneumothorax. Because in tension pneumothorax, there will be increased intrathoracic pressure. The intrathoracic pressure will be increased because of a one-way valve that will let the air go into the thoracic cavity but will not go out. So with every breath the patient takes, this will increase the intrathoracic pressure, and this will make the alveoli collapse on each other, and this will lead to hypoventilation, and the increased intrathoracic pressure also will lead to preventing the venous return to the right heart. So we can say that tension pneumothorax is like cardiac tamponade, with adding that there will be auscultatory finding on the lung, like there is decreased breath sounds and tracheal deviation away from the site of the tension pneumothorax. So we should think about these three things. So the first question we want to ask to ourselves is there any signs of internal or external bleeding? Because if there is any signs of internal or external bleeding, so that's it. We already know the diagnosis, and this is bleeding from and that will lead to hypovolemic shock. So if there is not, or if there is state of JVP we will think about. And what is the state of JVP? Is it increased? So the next thing we will say here, it's either tamponade or tension pneumothorax. So what will differentiate cardiac tamponade from tension pneumothorax is auscultatory findings and APG. So what is the state of the lung through auscultation? If there is tracheal shifting and decreased lung sounds in one part and the hypoxemia in APG, so this is tension pneumothorax. So according to our case, this patient is hemodynamically unstable. There is no signs of internal external bleeding. JVP is elevated. Pulmonary auscultation showed decreased lung sounds on the left side with tracheal deviation. APG showed hypoxemia and hypocapnia. The cause of hypocapnia here is from hyper or increased respiratory rate due to hypoxemia. Carbon dioxide is easily washed out with increased respiratory rate, unlike oxygen. So the answer here is clear, which is tension pneumothorax. So this will lead us to think about why it's not pulmonary embolism here. In the context of trauma, in pulmonary embolism here, we should think about pulmonary embolism because in pulmonary embolism there's increased JVP because the blood clot is preventing the blood flow from the right ventricle to the pulmonary circulation. And this will lead to decreased venous return to the left heart with hypotension and tachycardia. And also APG will show hypoxemia and hypocapnia due to ventilation-perfusion mismatch. But in the context of trauma, we should not really think about pulmonary embolism unless the patient is bedridden for 24 hours. So this will make the diagnosis of pulmonary embolism unlikely. And also in pulmonary embolism, pulmonary auscultation is usually normal, unless if there is any pleural effusion in the basal lung fields that will decrease auscultatory lung sounds on the basal lung, but not all over the lung, or one part, or one unilateral part of the lung with tracheal deviation. So this will make pulmonary embolism unlikely. So the answer here would be tension pneumothorax. So to summarize, hemodynamic instability in the context of trauma, we would say shock after trauma. We would check for bleeding. We would assess JVP, lung auscultation, and APG. If there is low JVP, normal lung and APG, plus or minus signs of bleeding, because we say that the bleeding may be internal and we cannot see it. So that's it, it's hemorrhagic shock. If there is high JVP and normal lung and APG, so the most likely diagnosis may be cardiac tamponade. If there is high JVP and abnormal lung and abnormal APG, the most likely diagnosis should be tension pneumothorax. And this concludes our section of hemodynamic instability in the context of trauma.